Thank you, sir. I would like to thank you for making me a part of this course, and I would be speaking to all of you about the phacoemulsification in torn capsulorhexis. Now, phacoemulsification in torn capsulorhexis, earlier people would convert to extracapsular cataract surgery, but nowadays, with the recent techniques, technology, and modifications, it is still possible to do it. The incidence in various studies has been reported to be 1%, and the factors which determine whether you will continue to do a phaco or convert are the density of the lens, the size of the capsulorhexis, and the most important is the experience of the surgeon. The dangers of an errant or a escaping capsulorhexis is that an anterior capsulorhexis tear can go from the capsular fornix and convert to a posterior capsular tear at any point whenever you are doing any nuclear emulsification maneuvers or intraocular lens implantation. Now, this is a case of a white cataract where the anterior capsule has already been stained by the trypan blue dye, and capsulorhexis forceps is being done with the help of a capsulorhexis forceps because it gives better control in these cases where there are more chances of the rhexis going into the periphery, as happens in this case. Now, whenever this happens, one should inject viscoelastic from the side port before withdrawing the instrument, and one should re-grasp the leading edge of the capsulorhexis after identifying it and then complete the rhexis. So the rhexis is circular and is continuous even though it may not be, it is regular and continuous even though it may not be a perfect circle. Now, this is a case of leukomatous corneal opacity wherein again the trypan blue dye is being used to stain the anterior capsule. The nick is given from an area wherein the capsule, the anterior capsule is visible, and after again using the viscoelastic agent with the help of the capsulorhexis forceps, the rhexis is being done. In such cases, it is better to do as large a rhexis as possible because you would need to do a phacoemulsification which may not be central, which may be a little bit eccentric. And when you come to that area wherein the opacified part is present, it is imperative that you do not leave the edge of the rhexis, because if once lost, then it will be very difficult to retrieve it from underneath the opacified part of the cornea. So just beneath that opacity, try to take the capsulorhexis tear in one go. This is the study where we compared the various dyes with the autologous RBC, and we found that the various dyes which are available were superior to the autologous RBC as well as the fluorescein stain, and this was a randomized control trial that we did and we published. Now, at times you may not have stained the anterior capsule where the reflex is relatively better, such as in this case, and because of excessive needling, you lose the edge of the rhexis in the cortex. So, in such cases, it is imperative and it is very useful to stain the anterior capsule post facto, that is, after the leading edge of the rhexis has been lost. One can still stain with the trypan blue dye, locate the leading edge of the rhexis, and then complete the capsulorhexis with the capsulorhexis forceps, as was done in this case. This is a case of white cataract with coloboma, and the staining with the trypan blue dye just unmasks the fibrosis that is present underneath, and in such case it is always better to do a ECC IOL than a phacoemulsification. And at times you can stain again, know where the fibrosis is present, and take the entire fibrosis into your capsulorhexis with the help of the capsulorhexis forceps, so that the nuclear emulsification can be undertaken successfully. Now, this is a case where the last piece of the nucleus is left, and while chopping there is an inadvertent tear which has occurred in the capsulorhexis margin. And when this occurs, then of course, even during the last piece of nuclear phacoemulsification, the parameters have to be lowered. The flow rate, the aspiration rate has to be lowered, and viscoelastic is then injected. Again, not too much, because otherwise that rhexis can go towards the posterior capsule and cause a tear. Now, this is again a case of white cataract, where the rhexis was initiated with the cystotome needle and was and was then and as the rhexis was being done with the help of a capsulorhexis forceps, it could not be completed because it ripped towards the conclusion of the completion, and at this point in time again one should inject viscoelastic and then withdraw the instrument which is present inside. The rhexis edge which was accessible from the wound was then cut with the help of the Vanna scissors. Again, the subsequent maneuvers have to be very gentle. The gentle hydrodissection is done in these cases, followed by phacoemulsification in situ. That is, you just emulsify the fragments wherein they are present without causing much rotation, because there's already a keyhole rhexis which is there towards the edge. So emulsify the nuclear fragments and consume them simultaneously, because that helps to actually decrease the intracapsular pressure that is present and also create space for the rest of the nuclear fragments to move. And this is more important in cases where the rhexis has gone astray and where you have a keyhole rhexis. Again, whenever you withdraw the instruments, the viscoelastic has to be injected from the side port so that it doesn't extend. And all your parameters at this point in time are going to be towards the lower side, that is the low vacuum, low aspiration rate, and low bottle height. And again, the phacoemulsification should be done in situ, that is just chop the fragments there and consume them simultaneously, so that the contents, the pressure in the bag is released. A bimanual irrigation aspiration should be done in these cases, because it helps you to know actually where you are aspirating, especially in the area where especially in the torn area. It helps you to know, to distinguish between the cortex as well as the margin of the torn rhexis. Now, 3-piece intraocular lens is being injected here, and notice that as again the capsular, you have to see the capsular morphology. As soon as you see the PC, as soon as you see the stria in the posterior capsule from the side port, you inject viscoelastic so that there is some space created for the intraocular lens implantation. Again, this is a case of post-penetrating keratoplastic cataract where capsulorhexis was done and a circular capsulorhexis was obtained, but as a nuclear emulsification was being done, the phaco probe actually chopped the rhexis. Phaco probe caused an impression on the torn margin of the rhexis. Again, in these cases, the immediate precaution is that one has to move more towards yourself, more towards centrally, so that the tags of the chopped rhexis do not come in the phaco probe. And again, in situ phacoemulsification should be done in these cases, and the parameters have to be lower down. Now, this is a case of 16-year-old girl with IDDM, insulin-dependent diabetes mellitus, with white cataract. As soon as a nick was given, the milky fluid was seen, which came out, and it became absolutely impossible to see where the margins of the rhexis were because of the milky fluid. So, because this was also a young girl, we could get away with irrigation aspiration. And after doing irrigation aspiration against the against the red glow that is present, it was possible to discern the margins of the rhexis, which was quite irregular. Margins of, in fact, the nick which was given, which was quite irregular. And viscoelastic is then injected from the side port before withdrawing the irrigation aspiration port to inflate the capsular bag. And whatever the zigzag topography of the tear was, that was converted into circular rhexis. Vanna's scissors was used to cut the margin of the tear so as to give a direction, because it is difficult to do a rhexis when all the lenticular contents have already been removed. And again, it is done with the capsulorhexis forceps because that gives a better control. And although it is not a perfect circle, but still it is continuous, and this is done basically to prevent post-op fibrosis and contracture that can occur after the implantation of the intraocular lens. And again, when you're coming towards the wound, it becomes a little difficult to complete because that is the margin where it has torn initially. So it is cut with the help of the Varner scissors, and intraocular bimanual irrigation aspiration is done, followed by intraocular lens implantation. What not to implant in case of a torn CCC? The capsule tension ring and the plate haptic design IOL should never be implanted whenever there is a torn anterior capsular rhexis. So the caveats to perform phacoemulsification in a case which has torn rhexis are that one should convert to a SICS or ECC if you are not confident of it. But if you think you can get away with it, then salvage the rhexis. Gentle hydromaneuvers and nuclear rotation should be done. The parameters should be on the lower side, low bottle height, vacuum and aspiration. Preferably do phacoemulsification in situ, a bimanual irrigation aspiration, and careful intraocular lens implantation. Thank you for your attention.